trying to time you as well. Okay, so this is your station.
Okay.
Yeah, so your time starts now. It's 11:09. Take 2 minutes, and then we will start at 11:11.
Okay.
If you're ready to start, we can start. Otherwise, we can give you another 1 minute.
Yeah, I'm ready to start.
Okay, let's start then. Yeah, we'll try to save as much time so that we can discuss more. Okay, you can start now.
Okay. Hello, I'm Dr. Adila. I am the doctor covering the gynae clinic today. Can I confirm your name and age, please?
Yeah, I am Emily Brighton and I'm 19 years.
And what would you like me to call you?
Emily is fine.
Okay. Emily, I can see that you have been admitted 2 weeks ago to the A&E with pain, and now there is some scan had been done for you, and you are here today to discuss the result. Is that right?
Yeah, I mean, I'm not very sure about the scan report, but I'm still having some pain, so that's why they referred me back to the ward.
Okay. I'm so sorry to hear that. Can you? I would like to ask you a few questions to know more about your complaint, and then together we will discuss what is the next step in your management. All right?
Okay, that's fine, yeah.
Okay. So, Emily, could you tell me more about this pain?
So I'm having this dull ache all the time since I was admitted last time. So
Mm-hmm.
actually 2 weeks back I had severe pain which then settled with some painkillers they gave me in the hospital. Then I was sent home and I had this ultrasound scan in the meantime. And my GP asked me to come back to the gynae OPD, but the date is like after 3 weeks. But since I had this pain, so I just thought to come to the hospital because it's there again, and I'm quite worried.
Okay. I'm here to address all your concern. So,
Mm-hmm.
Emily, are you comfortable to talk and to take this consultation?
Yeah, it's fine at the moment.
Do you want me to give you any painkiller?
Oh, okay, yeah, so that would be really great, yeah.
Okay, I will ask my nurse to give you some painkiller while we are discussing your condition. All right?
Okay, thank you.
Okay. So, could you tell me more? Is this pain like associated with anything that aggravate the pain?
Not really. It's sometimes when I'm walking, it's a little bit more, but I mean, since I have gone back home when I was admitted, there is a constant dull pain, and most of the time it's always there. So I can't tell you exactly what makes it better or worse, but sometimes movement, yes.
Okay. And is this pain associated with any discharge?
No,
Discharge? Any bleeding?
no,
Okay. And do you had any similar condition before this?
no.
Okay. And is your cycle regular?
Yes, my cycle is fine.
Okay. And when was the last period?
2 weeks back when I had this pain, so when I came to the hospital, I was having my periods.
Okay. And is this pain associated with any vomiting?
No,
Did you notice any like loss of weight,
no.
any loss of appetite?
No, I'm just feeling a little full in my lower tummy. That's it. Yeah.
Okay, okay. Okay. And are you with someone right now?
Yes, I am.
Okay. And are you sexually active?
Yes, I am.
Okay. And Emily, have you or your partner had any sexually transmitted disease before?
I don't know.
Okay, right. Emily, have you ever been pregnant before?
No.
All right. And did you have any medical condition that you follow with your GP?
No, I'm generally okay. Yeah.
If you can, all right.
Yeah.
So, are you taking any medication right now?
No.
No. And are you allergic to anything?
No.
Any surgery in your tummy or
No.
down?
No.
No.
Never. No.
Any family history of concern?
No.
No. Okay. Um, so, what do you do for a living, Emily?
I'm a student, and actually, I'm quite worried because I'm having my exam in the next 2 weeks. So I was very busy with my studies, and I have paid a lot of money to take that exam, and I'm really worried that this has happened. Okay, so okay. Would you like to give me some pain relief now? I'm having more pain.
Yes, of course. Yes. Okay. Yeah. The pain relief is coming. Okay.
Mhm.
My nurse now she will give it to you.
Okay.
Are you comfortable to speak now?
Yeah, it's fine. Yeah.
It's fine.
Yeah.
Okay. Yeah. So yeah, I can see the pain is come and goes. Yeah.
Yeah.
All right. All right. Okay. So Emily, do you know your BMI?
It's normal. I think
Okay.
it's 20.
20 million. And do you know your blood group by any chance?
No.
Okay. And with whom do you live?
I live with my partner.
Okay. And is everything at home fine?
Yeah.
Okay. Okay. Thank you for sharing this information with me, Emily. All
Mhm.
right. Okay. I would like to examine you.
Mhm.
Right.
Okay.
I will take general, yeah, vital signs, and then I will see your tummy, right?
Okay.
Okay, and yeah. So coming to discuss the result of the scan with you, Emily. Is
Mhm.
anyone discussed with you the result before?
No, I don't know.
Okay. Do you have any like expectation what it could be?
No, I don't know. But the doctor just mentioned last time that it could be a cyst in my ovary. Is there any cyst?
Okay. Yes. I will come to discuss in more detail the report. All right.
Mhm.
So I confirm the scan report is belong to you by your
Mhm.
name and date of birth and NHS number,
Mhm.
hospital number as well.
Hmm.
So Emily, the scan showed that your womb is fine and normal size. Your left ovary and the tube they are also normal. Okay, but they have some concern regarding the right ovary.
Mhm.
It shows that there is cyst and the cyst is 13 times 10 centimeter, which is the big cyst.
Mhm.
Also, there is some features of the cyst that consist with some kind of the cyst. We call it dermoid cyst. This kind of the cyst, did you hear about it before?
No, I mean you are saying that it is quite a big cyst. It be a cancer?
Um, it is unlikely to be a cancer because this kind of cyst is common at your age.
Mhm.
But the only way to know that if it is a cancer or not is just when we remove the cyst and then send it to discuss under a microscope by a specialist doctor. Right?
Okay. So, but I'm having my exams in the next 2 weeks. So, what is the plan at the moment?
Yes, I'm sure you are worried, but Emily, the cyst is very big, and this is the reason why you have this pain because the cyst is twisted on itself.
Hmm.
So this pain is come and goes, and if we did not interfere immediately by doing surgery on operation.
Mm.
This cyst it will twist in itself, and you will be in a severe pain again, and this may be lead to a threatening condition. The cyst may rupture, and maybe the cyst, the blood coming to the cyst may stop, and this may change to something we call gangrene, and you may lose the ovary as well.
Oh God, that's very scary. So what are we going to do now?
I'm really sorry, I did not want to scare you, but really the cyst is very big, and as there is some features, the cyst is look like a dermoid cyst, which is common in your age.
Mm.
If this rupture happened, if the spill happened into your tummy, this may lead also to a condition. I don't want to scare you, but I would like to explain to you what is your condition. Okay.
Okay.
So the only way to manage your condition is by doing surgery. This surgery is to be a keyhole surgery
Mm.
by removing the cyst. All right.
Okay.
Yeah, it is. It will be a day case surgery, but because you are worried about your exam,
Your
so the
time is
keyhole.
up, but I'm giving you some chance to complete your station.
Okay,
Hmm.
by keyhole surgery or by open surgery,
Mm-hmm.
as the cyst is big, and there is a risk that may rupture. So I will discuss with my consultant. All right.
Okay.
Yeah,
But
and
what about my exam? I'm really worried that my exam is just ahead, and if I have an operation, will I be able to take my exam?
when was your exam? When will
It's
be?
in 2 weeks' time.
In 2 weeks. If we gone for a keyhole surgery, after 1 week you will return back to your daily activities or normal life.
Mm-hmm.
And meanwhile, we can write to your university about your condition so that you can postpone your exam. I know you are worried. This is also a possibility we can do. We can support you regarding this.
But I have given
Um,
a lot of money to take that exam. I'm a bit worried about the fee that I have paid, because if I don't take the exam, it will be a problem for me to, pay the fee again. Okay,
we
so
can we can discuss with your exam. Also, I would like to discuss with you after the operation. We will take the sample, the ovary, to discuss it under microscope, and we will discuss with you later the result of the histopath, the tissue.
okay, so let's stop it here. Okay,
Yes,
thank
yeah.
you very much. Okay, so would someone like to give a feedback? Dinesh, do you want to give a feedback?
Hello, hello. Can you hear me, ma'am?
Yeah, it's a bit faint, but we can hear you.
Yeah, actually, ma'am, it is very nicely done station, and the plus points that information gathering was complete. She elaborated the patient's all the symptoms in detail,
Hmm.
and offered sympathy, pen relief medications, rule out allergies, then discussed the patient's management in patient-friendly language, put a concern for her exam too, and it could I think in management we could add as it is a 19-year girl and with a complex ovarian cyst or any cyst in a patient
Sorry, your
complex is
voice
less
is
than 40.
voice has just dropped. I can't hear you.
Can you hear me, ma'am, now?
Yes, it's better.
Yeah, so complex is less than 40, so I think three tumor markers we can offer.
Mm-hmm.
And discussing about laparoscopy and laparotomy, the chances of having the spillage and considering the bigger size of the cyst, it would be a better option for laparotomy. But again, we'll discuss with the consultant.
Mm-hmm.
And yeah, these things we can add, and maybe just because she's post, like we know that it is a ovarian cyst, so just we can cut short some things related to the differential for the pain, because I think we are much more closer to the differential of pain.
Hmm.
So I think
Exactly.
these things I felt
Hmm.
rest of the things are okay, like
Uh,
really nicely done.
Okay.
Doctor, I have a comment. I'm Mona.
Okay, Puna, yeah.
I think we need to do MRI first,
Mm-hmm.
and then to evaluate the cyst further.
Mm-hmm.
And we will inform also about the risk of the ovarian torsion as she wants to go the exam. We'll inform her about the ovarian torsion that it can happen, and she may lose the ovary, and this may lose the function of the ovary as well.
Okay. Yeah. Thank
Yes.
you. Okay. Anybody else would like to add something?
Hello, can I?
Yes, please. Yeah.
Thank you. Just to explain that about the alpha fetoprotein, that beta HCG and LDH, and also the MDT meeting, that to arrange MDT meeting for her, because it is complex cyst,
Okay.
to exclude that is there any other problem, and MRI need to be done. If she is not, but if she is severe pain and now, so we will offer her for admission. If she refuse, then we can tell her red flag sign that if she has any severe bleeding, severe pain, and any emergency situation, she has to come if she refuse admission.
Okay.
So she need at the time life-threatening condition, we have to give her that the situation that what will happen, and need emergency operation at that time. Otherwise, if she after giving pain relief, if she is okay, she doesn't like admission, then we can explain to her about the all investigation and the MDT referral. Then we'll contact with her about the surgery
Okay.
and further management plan. Thank you.
Yeah, thank you. Yeah, so okay, so let's first discuss your performance. Your name is Adila, right?
Yes, I'm Adila, but
Adila,
my
yeah,
name in
okay,
Telegram
yeah,
is
Adila, okay,
Mustafa.
yeah.
Yeah.
Yeah, thank you so much for coming forward. You took a very good history. You were very empathetic. Your voice was really nice and empathetic, and you offered her pain relief. You were confident in discussion. So the only thing is that your information gathering took a very long time. It was more than 5 minutes. Okay. So this is what obviously we have to learn, that you have to complete your history within 4 minutes so that you have more time for discussion. Because, and also like in this scenario, you have asked about allergies, family history, everything. That was really good, but it has to be cut short. There are certain things that can be cut short. Okay, and you were asking about BMI and blood group. I think you can skip these bits just to because she's here to discuss her options. And also of note is the thing that she was admitted 2 weeks back with pain. She has come back with pain again, and she is asking you pain relief. So it is quite possible that this is a dermoid cyst which is torted at the moment, isn't it? This is the first diagnosis which is there in our mind. And when she's telling you again and again that I have my exam, I'm very concerned, I have paid a lot of money, so what you can offer her is a sick note. Okay, so you can tell that I completely understand your concern, and I know that you are very worried about your exam, but at the moment we are a bit concerned about your health. Okay, so these are the options for you: wait and watch, which is not the recommended option in this situation, isn't it? Will we wait if we think that it's a torsion of ovary? Because she's a 19 years old girl, she will lose her ovary if we wait. My opinion is that she should be admitted, as Salma said, that she should be admitted in the hospital, and she should be offered surgery. Obviously we cannot pressurize a patient, but we can see what concerns are there. For example, if she's refusing surgery because of her studies or whatever, and we also tell her that there is a risk of losing her ovary, so obviously we have to be very clear in explaining the things so that they can make a right decision, and at the same time facilitate them uh, for whatever concerns they have. So I think we can offer her a sick note and give her options of, obviously there are three options for you basically: wait and watch, which in this situation is not a good option because you have presented second time. This is not the recommended option because you have presented second time and the cyst is big, and in this situation it is quite possible that the cyst is twisting on itself. We cannot tell you that what is happening exactly, but obviously unless we do a surgery. Okay, So in terms of surgery, as you rightly said, that basically there are two options: laparoscopy, which is a keyhole surgery, and laparotomy, which is an open surgery. Because of the size of the cyst, there is a chance that we may have to proceed to an open surgery if it's not possible to remove the cyst through the keyhole surgery. But since as an ST5 you are not competent and you are not signed off to do such kind of surgeries, you will involve your consultant in the decision making.
Yes. Okay.
Okay, so my opinion, just to summarize this case, is that basically the things were that she's a young patient, presented second time, and there is a high chance that this ovary is being torted, so we will admit her. This is the safest option. Okay, admit her and discuss with your consultant. Okay, and if the patient still does want to go home, like for example, I'm just telling you just in case, for example, if the patient does not understand what is the best thing for her, then obviously you will have to escalate it to your consultant. Okay, don't take it on your shoulders, you have to escalate it, so that obviously the consultant will have a chat with them during their admission.
Okay.
Is that clear, everyone?
Yes. Do we need to do any investigation?
Obviously before surgery, and also you have to ask about her support at home, because if she has a surgery, she goes back home, obviously there are a lot of things. For example, she may ask you about laparoscopy, but in one station they will not expect you to do everything. Okay, but it's important to make sure that she has got enough support at home, so that if she is discharged home, there is somebody to look after her for the initial days. Okay.
Okay.
And a sick note may be helpful, because she's saying again and again that I have paid a lot of fee for my exam. So a sick note may be helpful, that in case she is not able to take the exam, this is for medical reasons, so that the her department or her college or university can facilitate her later for the exam.
Okay.
Okay, obviously because the medical emergencies can arise anytime.
Yes. Correct.
Okay.
Thank you so much. Yeah. Thank
Yeah,
you
so
for giving me this
basically,
time.
as you have explained, you explained everything quite well. Obviously everybody has got a different style of telling things to the patients, but basically you can tell the dermoid cysts are the cysts if they want to know that do you want are you aware of the ultrasound scan report. She will say no, I don't have any idea. So this is why because they want you to explain it to the patient. They want to see your skills, your communication skills. There were a few jargons that you used, like gangrene. Okay, so it's better to use simple words like a dead ovary. Okay, so you can say that if this for example, if you are in the face-to-face exam, you can draw a cyst and the pedicle and tell them that, see, this is the ovary, and this is the cyst arising from the ovary, and this is the pedicle or the attachment of the cyst to the ovary. In case it twists, obviously it's easy to draw it in a face-to-face exam. In an online exam, because they will be looking at you, so you can explain or illustrate using your hands, that if it twists on itself, then there is a risk that the blood supply will be cut off, which can lead to a dead ovary. Obviously we do not want it to be like that, because there is a risk of you losing the ovary. Okay, so that is why it's important to do the surgery earlier than later. Okay, so this is what I have just copied basically from somewhere. The dermoid cysts basically develop from the cells that are used to create eggs. Since the eggs have an ability to create any type of cells, so dermoid cysts can consist of a wide range of different types of human tissues. Like, so you can just simplify it, that in case they want to know that what is a dermoid cyst. Okay. Always ask open questions, so that they tell you most of the things. Like in terms of pain, you asked everything basically. Your history taking was really good, but you didn't ask about any bladder or bowel symptoms. You asked about weight loss, appetite, and always signpost, because you asked about, I think you said that, are you with someone, and then you asked about sexually shared infections and also about sexual history, sexually active. So it's better to signpost before that. Okay, and options are obviously wait and watch, as we discussed, which is not a suitable option in my opinion in this case. When we know that there is a dermoid cyst, the patient has presented second time, she's asking pain relief, so it's better to admit her, escalate it, discuss with your consultant, and give her option of surgery, which is the recommended option from our side at the moment. And if she wants to know more about that, then obviously you can tell her the pros and cons of each option. And if we leave it, then obviously risk of a torsion and emergency surgery. And then if there is a situation, for example, if this woman is not presenting, okay, one more thing, let me just tell you this. These words, each and every word here is very important. So you are an ST5 in gynae ward and about to see this lady in gynae triage. So gynae triage is a gynae emergency. Okay,
Mhm.
so
Okay.
patients are referred to gynae triage or gynae emergency from GPs or A&E or different places. So then the gynae registrar accepts the patient. They generally receive a phone call. They accept the patient. So this is an emergency. This is not an OPD situation. So if the patient is in the OPD, obviously then you can give her tell her about red flags, emergency contact number, and negotiate regarding the sick note for exam, as she was asking about that again and again. And I think that we should discuss this case with the consultant and also discuss with the anesthetist, because she may need surgery, and book an emergency surgery for this lady. Okay,
Okay.
thank you so much, very well done. Yeah, it's
Thank
just a
you.
matter of time. So if you could time your history to obviously 4 minutes or less than 5 minutes, then you will have at least 6-7 minutes to discuss the management options. So that would be really great. Otherwise, your communication is really good. You are empathetic, and hopefully you will be able to do it very easily.
Okay. Thank you so
Okay.
much for giving me this chance.
No worries. Thank you. Okay, who is the next person in
Excuse
the
me,
line?
Dr. Amara.
Hmm?
That as it is complex cyst,
Mhm.
so no need to do that alpha fetoprotein, LDH, and
Yes.
MRI. No
No,
need.
I think we can do these tumor markers, but since it's a dermoid cyst, we don't need to wait for the tumor markers and do an MRI or MDT because she's in pain at the moment, isn't it?
Right.
Yeah.
Yeah.
So if, for example, if she comes like an OPD case and then she has got a dermoid, like a complex cyst, and we are a bit concerned that obviously this is a complex mass and it needs to be investigated further, so she will have tumor markers or and further investigations.
Hmm.
And obviously,
But
in that situation, we will also refer her to the MDT.
okay, you know that last exam it came only they didn't mention anything,
Hmm.
only the ovarian mass, and it is, I think 6 centimeter, six. It is big cyst, but not mention is it complex or any other things.
Hmm.
So at the time we can say that we need to do the more information to see the MRI. Yeah,
Yeah, if the patient is not in acute symptoms.
yeah, she's not acute symptom,
Yeah.
but the cyst doesn't mention that it is complex or simple. Anything they didn't mention.
Okay. Yeah. Obviously, we need to in a situation like, for example, many times we will do some stations later on as well. Many times they do not mention a lot of things, and so in that situation, you will tell them that I would like to know a little bit more about uh, this cyst. Yeah, the characters of the cyst. Yeah.
Yeah. Okay. Thank you.
No worries.
Can I do next session, Dr. Amara?
Uh, just a second. Sorry, you are Salma, right?
Yes.
Okay, Salma. Actually, we I don't know. You have seen the last messages in the group. So there was Falak, Umme Mustafa, Salma. Actually, you you sent a message earlier, and Mona. So which means that we will go by this sequence. So I'll wait for Falak. If she's here, she can do
Okay.
one, and Salma, you can do one, and then Mona, then Suninda message later. So we will give Suninda and Dinesh a chance in the next one. Yeah. Actually, I prepared 4 stations. Okay.
Okay. Thank
All
you.
right. Okay. Perfect. Let's go back.
Hello, I'm there actually. I got stuck in my work.
Who's this?
Hello,
Sunanda. Yeah, Sunanda.
can you
Actually,
hear? Yeah, yeah.
yeah. So we saw the sequence of the messages that everybody sent. I'm not going to go into the details of this key,
It's
so
okay,
that
no
we can
problem.
move. Okay.
No
Yeah.
issues.
Okay.
Yeah.
Yeah. All right. Okay.
Can
So,
I see the second slide, please? This
sorry.
previous slide.
Previous slide.
Previous session, what was discussed? Can I see the second slide?
Yes. Just a second. Sorry. Yeah. Falak, do you want to take the next one?
Next slide, please. I'm so sorry.
This one?
Yes, Dr. Mara, I can see.
Okay.
I think next one.
This one?
Yeah. Thank you.
No worries. I've got a few slides for you, few more slides as a key of this one, but we are just going ahead to the next station so that we can cover all 4 stations today, okay?
Yes.
Okay, Falak, I'm just going to bring up a station for you.
Okay.
Okay, so it's here.
Can I see the next slide, please?
Yes. Okay. Yeah, I think
Dr.
we
Mara?
got two slides.
Dr. Mara, can I say something?
Yeah.
I am not prepared for this station. I don't think I would be able to do in the proper way
Mm-hmm.
because I've never done it before, and it would be better if someone else can take it.
Can,
Otherwise, yeah.
can I join?
Okay, yeah. That's fine, Falak.
Can I try another one then?
Okay, that's fine. Yeah, no problem.
Thank you.
So, Salma, you are doing this?
Yes.
I'm
thank
bringing
you.
up the previous slide again. Do you want the next slide? Whenever you want, let me know.
Yeah, thank you. Yes, next slide. Yeah, previous one.
I'll leave this slide here. Don't worry.
Yeah.
Okay. Should we start?
Yeah.
Okay.
Hello, I'm Dr. Salma, one of the doctor in the antenatal clinic today. May I check your name is, please?
Yeah, I'm Victoria Miller and 35.
What would you like me to call you?
Victoria is fine.
Victoria, I understand that you are 20-week pregnant and you came here today to know about your report and further management plan. Am I right?
Yes.
Yeah, so is it okay before explaining your report if I'll ask you some relevant question, then at the end I'll give you written information? How does it sound?
Yeah, that's fine. But is the report okay, doctor?
Yeah, actually, report there is some, concern. So do you want me to explain report first, or I can take some relevant history?
If you think that history is important, you can. Yeah, I'm happy. Yeah.
Yeah, whatever it is, I can go, no problem,
Okay.
according to your wish.
Okay. Yeah. I'm happy
Yeah,
to. Happy to answer your questions. That's fine.
okay. So can you tell me, do you have any problem that with this pregnancy? Can you tell me about your condition?
my pregnancy was going very well. Everything was okay. All the tests, ultrasounds previously. Yeah, so everything was okay up till now.
Mm-hmm. And do you feel any movement, baby movement?
Not yet.
Mm-hmm. And what about your previous pregnancy? Everything was fine?
Yeah, so I had my previous
Baby.
pregnancy 14 years back, and
Mm-hmm.
that was with my previous partner, and this is a new partner actually. And sorry, this is an IVF pregnancy. And otherwise, that pregnancy was okay, and I had a normal delivery, very straightforward. Yeah,
And baby is fine. Any problem with baby?
no,
Mm-hmm.
my son is
Uh,
fine. He goes to school, very brilliant.
Good. Nice to hear that. Do you have any medical disease that you are following to GP?
No,
Mm-hmm. And any family history of any the genetic problem,
no.
any other medical disease that you want to share?
Uh, no, everything is okay actually, but I'm
Mm.
a bit concerned about this report now. That what is the problem? That why have they referred me here? Because as I told you, my previous pregnancy was quite straightforward, and this was
Yeah,
going well as well. Yeah.
yeah, I can see you are worried. I'm here to help and support you. Okay.
Okay.
Yeah. So, do you have any operation before?
No.
Do you smoke?
No.
Drink alcohol?
No.
Any recreational drug?
No.
Are you taking any medication now?
Not. I don't take any medicines. I never took any other medicines other than the folic acid and vitamin D.
All right. Yeah. Folic acid, how many milligram you took?
I take 400.
Right.
400 micrograms. Yeah.
Yeah. So, do you have allergy to any medication?
No.
Mm-hmm. Do you have enough support at home?
Yes, my partner is very supportive.
Mm-hmm. Thank you for sharing all information. Do you want to add anything?
No. Yeah.
Mm-hmm. So now coming to your report, yeah. So do you have any idea? Anybody explained to you?
Not really, but I was a bit surprised when they said to me that you can go downstairs and have a chat with the doctor there. Yeah.
Yeah. Can I see the uh, next slide? Yeah. So actually, your scan report says there is some concern. So do you have anybody with you that you may need support?
No, is everything okay? My partner is at work.
Mm-hmm. So do you want me to call nurse to stay with you?
No, it's fine. I mean, is my baby okay?
Um, Actually, you know that there is some concern in the scan. So that means the baby growth is okay, yeah, but there is that muscle which can separate from our chest and tummy. Okay, this muscle is divide that inside our tummy, the uh, upper part of the chest and the tummy. So that part, that muscle, there is a hole. Okay, so
There is a
uh,
hole.
hole in your baby, yeah, there is a hole, and then the gut and the it came out through that hole.
Oh God, I couldn't expect this. I was so happy that I will be having my 20-week scan today. Um, what will happen next?
I'm
I mean, we were looking forward to this pregnancy, and as I told you, this is an IVF pregnancy, very, very long awaited pregnancy. So, yeah, so I don't know.
I'm sorry to give you this information. Do you want me to call somebody? Are you okay?
Yeah,
Can I?
I mean, what are the options now?
Yeah, actually, there is an option available. Okay, so that if it is only this case, okay, so it is curable. But we need to do other. There is any other problem or not? Any genetic problem? Okay, so if want to know that, so we have to refer the specialist doctor in fetal medicine unit who are expert in this area.
Okay.
So he can do the details scan for you, that to for sorry, for your baby, that to see there is any other problem or not.
Okay.
Yeah. So and also he will do the needle test to see there is any genetic problem or not. Okay, so if there is other
What is
problem
the
and
needle
genetic
test?
problem,
They will
needle
take some
test,
blood.
it is actually to take fluid from around your baby, okay, and to see that there is any genetic problem or not. And there is a risk, 1 in 200, there is a miscarriage risk, but it will be done by expert doctor, so that it is safe to do, because the expert doctor will explain you everything about that. So if there is any other problem, then maybe some women, they like to termination the pregnancy, or some they like to continue the pregnancy. But if it is only this case, then there it is treatable.
Okay.
Do you want me to continue the conversation?
Yes, please. Yeah, I want
Yeah,
to know a bit more.
yeah,
Yeah.
yeah. So, what do you think about that needle test?
I don't know. I'll think about that. Are there any risks?
Uh, I told you that it is 1 in 200 that miscarriage risk only. Yeah.
Okay.
Okay. So,
Okay.
do you want to continue the pregnancy, or what do you think?
Mm, I'll have a chat with my partner when I go home.
Mhm.
Yeah.
So, if you want to continue the pregnancy, then you will be seen by specialist team. Okay, that means the fetal medicine unit doctor, the specialist doctor, our consultant, and specialist nurse, then scan doctor, the support group, all will be in your care. Okay, and you will be seen with more visit and more scan in consultative unit. And if everything is fine, okay, yeah,
Okay.
will then 36 weeks will take decision for mode of delivery, and anesthetist will discuss with you about the mode of delivery, sorry, mode of that pain relief. Okay, so you can discuss. Am I clear?
Yeah. I mean.
Yeah.
Okay. Yeah.
Yeah. Then during delivery also we'll do the continuous baby monitoring to see how is baby doing, and then after delivery, the baby doctor will discuss with you about the baby problem, and also before delivery also he will discuss with you. Okay, and after delivery, if there is any if it is
I think our
confirmed
time is
that
up.
time up. Okay,
Yeah. Okay.
so
Okay, so we can stop here. Who wants to give a feedback? A general feedback. I'm not expecting you to tell me everything about the diaphragmatic hernia, but a general feedback. Anybody?
Yeah, yeah, doctor. We of course, doctor did very well. But I have that we will inform her that we will refer you to fetal maternal unit. Uh, as this hold the contents inside the tummy may press on the or cause pressure on the lungs and may not allow the lung to grow properly as it should. And I'm afraid this will be a life-threatening condition for the baby.
Yeah.
Yeah, and also after then we'll inform about the amniocentesis and the risk of the miscarriage, one person, and then we will inform her a referral to counselor, as of course she will be the best if she wants to talk with counselor. And we inform her also as this may be associated with some chromosomal abnormalities as well. That's it.
Yeah. Anyone else?
Can I?
Yes, please. Who
Yeah.
is this?
Yeah, Vishnupriya here.
Okay.
Yeah, this is regarding Salma's station. She has done well. She addressed everything. Almost she has introduced, set an agenda. Then empathy was there. She has given warning shots. A bit more time management and a bit more in detail about. She covered FMU referral needle test, MDT. It was okay overall. She has done a good job.
Yeah, I agree with you because obviously it was not an easy station, and especially when you
Yeah.
haven't revised it for some time, then it's not easy to take. Thank you so much, Salma, for coming forward. Okay, so let's have a look at a few slides, the next slides,
Welcome.
so that
Thank
we.
you, Dr. Amara, to give me opportunity.
No worries. Okay, let's have a look at the next slides, and then we will. Let me first tell you about your performance. I think the first thing is, which is very important, is to come forward and take the station. And the best thing was that you took history in 3 minutes, which was really good because it is a long discussion. The patient will ask you a lot of questions, so that's really good that you took history quite quickly and very to the point history. You didn't go into details of everything. Okay, but what I would like to add here is, obviously we will discuss the management, but what I would like to add is that whenever patient is asking a lot of questions, or she starts to cry, or she becomes anxious, do not get confused. Okay, be prepared for this. So do not get confused, because you are the doctor, so you can, as you asked her that can I is it okay to continue the discussion, but it was slightly late. Okay, so when she said that I'm very anxious, this was an IVF pregnancy, so you got a bit confused. So do not get confused, because uh, you are a person with the knowledge, so you have to communicate your knowledge, and at the same time support the patient as well. So you are in a stronger position, so just support the patient. Okay, and yeah, so basically that was it. So let's have a look at the things that are important in this kind of station. Basically, a referral to FMU was really good, and obviously they will do a detailed scan to see if there are any other abnormalities. Left-sided diaphragmatic hernia is commoner as compared to right diaphragmatic hernia, and that has got a better prognosis as well. And as you have already mentioned that there is a risk of the stomach contents or the tummy contents going into the chest, and the lung development can be affected as well. So so these are the risks that we have to discuss with the patient. But referral to FMU was really good. And then amniocentesis, you can tell them that if there are what are the reasons for having a diaphragmatic hernia. If it is an isolated abnormality, the prognosis is generally better. If there are other abnormalities as well, like we are expecting some chromosomal abnormalities associated with this condition, if there are multiple abnormalities seen on ultrasound scan to detect the chromosomal abnormalities, then she will be offered the amniocentesis or the needle test. So you can tell her that, as you told, that they will take a little bit of fluid and check it in the lab. With regards to the termination of pregnancy, I think because it was a very wanted pregnancy, so do not give her termination of pregnancy as the first option. It is her right to opt for termination of pregnancy, because this was in my key that I will ask you for termination, but that was the first thing that you mentioned yourself. So I think that in such a scenario, when you can tell her that I'm really sorry to tell you that I'm afraid to tell you that there are some concerns regarding your baby's ultrasound scan. So there is a muscle which separates the tummy contents from the chest contents, which is called diaphragm, and the baby has got a hole in the diaphragm. And obviously if you can give pauses in between, check her understanding in between, so that's really good. And then you can tell her that since there are no other abnormalities which are detected on ultrasound scan today, so there is a possibility that the prognosis is good, but I will refer you to the fetal medicine unit. And if she asks further, obviously we will involve neonatologist in her case, we will involve the neonatal surgeon, so it will be an MDT. So mention about the MDT team involvement. Okay, who will be the best people. So you, if you do not quote any figures in terms of prognosis unless you are 100% sure, so you can tell them that an MDT involvement will be there in your case, and obviously they will discuss the long term prognosis for your baby. But there are options that after delivery the baby's this defect can also be repaired, and the other option is obviously if you do not want to continue pregnancy, the other option is termination, which some women go ahead with. Okay, and when and also you said that do you want to go ahead with termination, always give a patient some time. Okay, whenever there is such a situation, or in any situation. Okay, in any situation, even in OPD or anywhere, obviously when they come to the hospital, they are not expecting something like that happening, and it was obviously when she came for an ultrasound scan, referred to you, then she was not expecting that. So it's not an emergency, so you can give her time, and you can tell her, I'm here to give you the options today. You can go home, think about your options, have a chat with your partner, and come back to us. Is that okay? Do not feel pressurized with the discussion that we will be having today. Okay, so just to summarize, take a history, tell her the options that I will refer. In terms of MDT, you can tell them that I will refer you to the fetal medicine unit and inform my consultant as well. So your team your care will be taken over by an MDT now, which involves the fetal medicine unit, obstetric consultant, neonatal team, neonatal surgeon, and they will make a plan for you and your baby. Okay, and then obviously the second option is termination of pregnancy, but I'll give you an information leaflet before you go home, and do not feel pressurized because I completely understand it's very overwhelming to have a lot of information today. So this is how you can support them, and then obviously they will feel more confident, and it will also develop a good rapport. Okay, so basically this is what we have just discussed, everything that I have written here in this slide. Provide diagnosis and provide provision for appropriate information, because obviously unless we know that there is any other abnormality, we are not very sure about the prognosis. MDT involvement, offer choices, do nothing and continue pregnancy, further investigations, and then decide. That is also the patient's right. If she doesn't want to have amniocentesis, she doesn't want to take the risk of miscarriage or any other problems associated with that, it can be left. And termination of pregnancy. And it is also important, I'm just telling in terms of information, that if FMU is not available in your hospital, then the women can be referred to the tertiary care hospital, and treatment, and then neonatal follow-up. This is just a summary from the e-learning, RCOG e-learning. With regards to the diaphragmatic hernia, it can be associated with a chromosomal disorder, which can only be tested through amniocentesis, and occasionally it is not picked up during routine scans, and it is diagnosed shortly after birth. Just for the sake of information, not relevant to this task, but generally, extremely rarely it is diagnosed later in life during routine medical checkups. Risk of recurrence in this could also be a question by the patient. The risk of recurrence in future pregnancies is extremely low, and is given as a 2% increased risk, obviously, as compared to the general population. And if they want to know more about that, then they can be referred to a genetic counselor to discuss this increased risk. As we discussed, that it can be associated with the chromosomal disorder, and if it is a chromosomal disorder, then the prognosis will be relatively poor. Sorry, I think this is the same slide. Okay, extra antenatal appointments. So you can tell her that in addition to the routine care, now in this pregnancy you will have some additional care, and it will be an MDT. Sometimes more investigations may be needed. Obviously this is all for your information. It's not necessary that you will tell everything to the patient, but just give information in chunks and see what she wants to listen to. Okay, and these are again the repetition, that opportunity to meet the medical team. So you can tell her that we can arrange a further appointment so that you can meet the FMU and also the pediatric team, so that they can tell you more about the options after your baby is born. Women can have vaginal delivery. That is, these are different procedures that are done for repair of the diaphragmatic hernia. Only one center in UK does a repair, which is called FETO, which is done more commonly in the US. And delivery plan is vaginal delivery. She had a previous vaginal delivery. If we reach to that stage of discussion, then you can tell her that yes, she can have a vaginal delivery, and as soon as the baby is delivered, you will expect a few more people to come in, and because obviously the priority is to give best medical treatment to the baby as soon as the baby is born, and basically to give artificial ventilation. Yeah, so basically that is it. With regards to the abnormalities, we know that there are basically two categories of abnormalities that you will expect in exam. Some are serious abnormalities and some are isolated and correctable abnormalities. Okay, so these kind of abnormalities like congenital diaphragmatic hernia is one of these abnormalities, which is not a life-threatening abnormality, but it's the patient's choice whether she wants to continue pregnancy or not. If she wants to continue, then obviously the options are there, and in terms of repair. Okay, and if there is a serious abnormality like anencaph, holoprosencephaly, renal agenesis, which may lead to serious handicap, then you have to follow the steps of breaking bad news, like offering all the steps of breaking bad news, like offering them to call their partner and stuff like that that you have followed. Okay, is that okay? Should we move on to the next one, or anyone
Yeah.
wants to add something?
Thank you, Dr. Amara.
No worries.
Yeah, so do you think that I'll not ask about the patient that she want to continue or she wants to terminate the pregnancy?
No, you shouldn't ask. You should just give her options.
All
Okay?
right.
Yeah.
Yeah.
So you tell them whenever in exam you are not going to ask them. So always tell them, okay, so in this particular scenario there are basically three options for you: medical, surgical, and wait, expectant, medical, surgical. Okay. Similarly here as well, you tell them that there are two options, that I will refer you to the fetal medicine unit. They will investigate a bit further, and obviously treatment for the baby and stuff like that. The second option, if you do not want to continue this pregnancy, that is your right. Okay, so yeah. Okay, so she's still to 20 plus 4 weeks. It's not a life threatening abnormality, so she can still have termination, and if she does it after 22 weeks, it will be fetocide.
Okay.
Okay,
Thank you
so
very
give
much.
her options and let her decide herself whatever she wants.
Yeah.
Yeah.
Thank you very much.
Any other questions, or anything that anyone would like to add here? So this is basically the key that I have made. Maternal age is important, and history of present pregnancy, screening tests which were mentioned that they were all normal. Planned, unplanned, we knew that this is an IVF pregnancy. Medications in pregnancy or before, you covered that. Obstetric history you asked. Family history, smoking, alcohol, drug, everything you asked. Empathy, there was, I mean, you started well, but obviously when the patient started trying and she was asking again and again, then obviously you got a bit confused, but it was okay. So body language, obviously in online exam they can just see you see your face, so you can nod your head and bring forward your head. Better not use any jargons. I don't think you used any jargons. And address concerns side by side, and give impartial options, as we discussed, that just give her options. Do not tell her that you have to take a decision today or whatever. And with regards to communication with colleagues, community midwife will be involved, obviously, because they are looking after all the women. Fetal medicine unit, obstetric consultant, neonatologist, neonatal surgeon, pediatric surgeon. MDT is a buzzword, don't forget to use this. Okay, even if you forget to even if you've mentioned FMU and neonatologist and you use this MDT, that would be enough. Okay, and this is patient safety. Sorry, I didn't add the title, sorry. And this is positive patient identification is important, history, non-directional non-judgmental options, and referrals appropriately. And if there are any governance issues in any station, then obviously cover that. This is applied clinical knowledge, telling about all management options, chromosomal abnormalities and testing, as you mentioned, different types, and then apply the clinical your knowledge to that particular situation. Okay, should we move on to the next one?
Yes, please.
Okay, Falak, do you want to take the next one?
Yes, I do want to.
Dr. Amara, please, can you tell pass, borderline, or failed?
I think it would be borderline, not fail, because you were telling the options. You can just polish it and hopefully it should be okay.
Okay,
And
thank
your
you very
history
much.
was really good, very timely and very to the point.
Thank you.
Yeah. It's a very simple one.
Okay.
Okay, let's time you.
Any more slides, Dr. Mara?
I don't think so. Mona, do you want to take the next one?
Yes, doctor, I'm here.
Okay, be ready for the next one then. Thank you. Do you want to start?
Yes.
Okay, let's start.
Hello, I'm Dr. Falak. I'm one of the doctors in the antenatal clinic today. May I confirm your name and age?
Yeah, Tanya Wilson, and I'm 38.
How do you prefer to be called?
Tanya is fine.
Tanya, I understand that you are 36 weeks into your second pregnancy and you are here to discuss about your birth options. Is that right?
Yeah.
Any specific concerns that you want me to address today, Tanya?
No, it's just because I want to have a cesarean section this time. Yeah.
Mm-hmm. I do respect your wishes, Tanya. Is it okay if I ask you a few questions and then we can together make a safe and mutually agreed plan for you? Will that be okay?
Yeah. Thank you.
Tanya, Tanya, can you tell me a little bit more about your pregnancy?
This pregnancy.
Yes.
Yeah, my pregnancy is going so well. Everything is fine. To my knowledge, my ultrasounds, blood tests, all by the book. Yeah.
That's great. And have you named the little one?
Hmm?
Have you named your little one?
Yeah, so she is Rose.
And how is Rose doing? Is she kicking well?
Yeah.
That's lovely. Can you take me through your previous delivery, Tanya?
Okay, oh my goodness, I can't tell you how bad was that experience. Actually, my pregnancy was very well, just like this
Okay.
pregnancy, and everything went well till the time I went in labor. It was in a different hospital, and when I went in labor, uh, I was progressing quite well. And then my baby was in a different position. I pushed my baby for some time. Then the doctor came in and said, no, you need to be delivered in the theater using some forceps. And they took me to theater. It was such a traumatic experience that I can't explain how bad was that. Everybody was so rude. I didn't have any control on my body, and then they took me to the operation theater. They tried to turn my baby's head, and then they said that the baby is not turning. So why did you try to turn the baby? And then they did an operation, and I bled so much. And then I also had I think I had a bottle of blood as well. So it was a nightmare, literally.
I'm so sorry, Tanya, about your previous experience. I'm very sorry about that. I will try my level best that we provide you the best of care this time, and you don't have a similar experience. And I'm really sorry about your past experience. Can you just tell me how long ago was that?
My son is 3 years.
And is your son doing well now?
Yeah, he's fine. He's so cute.
That's great. And Tanya, how was your recovery? Was it all fine?
Yeah, I mean, I was physically, yes, but mentally, no. I was so traumatized by my experience. Thanks to my husband that he was very supportive, and my mother who looked after my baby. Otherwise, I had to do some counseling sessions because I was so traumatized by that experience. I don't want it to happen again.
I'm so sorry, Tanya. It must be very difficult for you. Tanya, are you aware of the type of cut that was given on your womb? Any idea about it?
No, I don't know.
Mhm.
They
Tanya,
didn't
would it
tell
be
me anything
okay?
afterwards. They didn't speak to me. I don't know anything about that.
Tanya, would it be okay if I request the hospital where you had your cesarean section and access your operative notes? Will that be okay?
Yeah.
Thank you so much, Tanya. Tanya, how many more kids do you plan in future?
I mean, I'm 38, maybe one more.
Okay. And Tanya, are you otherwise fit and fine?
Yeah, I'm fine.
Any allergies?
No.
Any medications you are taking on a regular basis?
No, just the pregnancy vitamins.
Any surgeries besides the cesarean section?
No.
Any reservations for blood transfusion if needed?
No, I had a bottle of blood last time as well. It's fine if it's needed.
Mm-hmm. And have you or anyone in your family ever had clots in the legs or lungs?
No.
And how is the support at home? You mentioned to me that your mother and your partner are very supportive. Do you live with your mother?
No, I live with my partner, but my mother lives close by as well, so that's
And he is supportive to you, right?
yes, he is. Yeah.
That's great. That's great. Thank you so much for sharing the information, Tanya. I would like to review your recent ultrasound scan just to make sure that your baby's growth and fluid around the baby and afterbirth are all fine. Will that be okay with you if I do that?
Yeah.
Thank you so much, Tanya. So, Tanya, you mentioned to me that you want to have a cesarean section this time. Is that right?
Yes, please. Yeah, but I know that the doctors are generally quite pushy to a vaginal delivery, which I don't want to try.
Yeah, I'm so sorry, Tanya, if you have been feeling this way. You have all the right to decide whatever you wish. It's just our responsibility to make you aware of all the possible options. And let me reassure you that whatever you decide, we will be supporting you in that.
Okay, that's reassuring. Thank you.
Mm-hmm. That's great. So, Tanya, having a cesarean section or having a vaginal birth are both very good options for you. Both are generally safe, and both of them have different risk and benefits, which I just want you to be aware of.
Mm.
Having a cesarean section is a good option. I think the particular reason why you want to have a cesarean section this time is because of your bad experience last time. Is that right?
Exactly. I mean, I think that having a cesarean section, I will at least have some control of the circumstances. It's not that, everything is so unpredictable. I may deliver, I may not deliver, and, I don't want this situation again.
Mm-hmm. Yes, Tanya, I can understand your concerns. There are different risks and benefits of having a repeat cesarean section, which we will together be going through.
Mm-hmm.
The benefit is obviously you are in control. You have a fixed date and you can plan your delivery according to that. And there are certain risks for you during a vaginal delivery that are minimized when you have a cesarean section. So, yes, it has some benefits, but it has some risk as well, which I want you to know.
Okay.
Since this would be your second cesarean, Tanya, there is a chance that your cesarean can be more complicated in terms of there could be some scar tissue in your tummy from your previous cesarean, which could put you at risk of having injury to your organs like bladder, your bowel, or the big vessels in the tummy.
Mm-hmm.
But usually we do it, the experts perform this operation and we are very careful during the operation, but the risk is still there, and that's why I want you to be aware of it.
Okay.
hmm There is a chance that your recovery might be delayed. You might need a prolonged hospital stay, and there are some risks that you might have infection in your wound. For that, we will be giving you antibiotics, and we will be very careful in the technique. But there is a chance.
Okay.
There is a chance, Tanya, that you can bleed. For that, we would be giving you certain medications to avoid the risk of bleeding, and you can also have some pain after your delivery. There are
Okay.
few risks for your baby as well. Your baby can have a cut on the skin. Usually, it's not very common. It's around 1 to 2 in 100, and we are very careful while doing it. But the risk is still there.
Okay.
Am I clear so far, Tanya?
Yeah, that's fine. Yeah.
Tanya, there is a chance that in your future pregnancies, your afterbirth can be stuck to the womb wall, and in your future pregnancies, you are planning a baby in future, right? You said you might have a baby in future, so there are chances that in your next pregnancy, your afterbirth can be stuck to the womb wall. So these are the risks I just want you to be aware of. The other option that we have for you, Tanya, is to have a normal delivery. Would you like to discuss about it?
I mean, I would like to know and compare it with cesarean, but I'm more inclined towards having a cesarean again.
Great. Tanya, we will just be discussing the risk and benefits of having a normal delivery, and rest the decision is yours. I will be supporting you in that. So, Tanya, the benefits of having a normal delivery this time are that you will have a quicker recovery. You can go back home early. You can have a immediate contact with your baby, skin to skin contact, and you can actually start breastfeeding immediately as well. Usually, 3 out of 4 women can successfully deliver after having uh, one cesarean section. But yes, there are chances that you might need an emergency operation as well. 1 out of 4 women might need an emergency operation if there are concerns on the baby's heartbeat, or if there are any concerns for you.
But if for example, I would like to go ahead with a vaginal birth, so because I want to avoid doctors altogether. So I did have a very bad experience previously. So is it possible to go to a midwifery-led unit?
Uh, there are some risks associated with having normal delivery after cesarean, Tanya. There is a chance that your womb, the scar on the womb, might open up. And in that scenario, it could be life threatening for you and your baby. So, that is why we usually don't prefer that you deliver in a midwifery led unit, because if an for suppose if a situation arises, you might need an emergency operation and emergency blood. And I'm sorry, I don't mean to scare you, but it could be life threatening for Lily and for you.
Okay. So
The reason why we don't advise you to deliver in a midwifery unit, we can do something for you. We have some consultant led midwifery units. They're actually located in the hospital. Uh, but the best option for you would be to deliver in a consultant led unit.
okay, all right. Yeah, I think I would like to go ahead with the cesarean then. Can you book a date for me today then? When can I have it?
Usually, Tanya, we plan it after 39 completed weeks of pregnancy. So yes, we can book a date for you. But before that, I would like to put you in touch with my consultant. You can actually have a chat with him as well. I can book an appointment for you in 1 week's time. And actually, we have consultant midwives also. If you are still confused after this discussion, I can actually put you in touch with them, and maybe they are able to help you in a better way.
Okay, that's fine. All right. Yeah. Thank you very much.
Any questions or any doubts so far?
No, thank you so much. Thanks for your help. It was very clear.
I can provide you with the information leaflet, Tanya. You don't need to make a decision today. We can book another appointment for you. At you can whatever you decide, we will be respecting that.
Okay, thank you. Thank you so much for your help.
Thank you so much for
Okay, take
thank you
care.
so much for your time, Tanya.
Okay.
Was I able to complete it in time?
Yeah, I think so. Yeah.
Okay.
I think we have still got a minute, or maybe it's just done.
Oh,
Yeah. Okay. Feedback. Who would like to give a feedback?
Can I
Dinesh?
tell something?
Oh yeah, yeah.
Yeah, yeah. She did very well. I think her confident and communication, everything is fine, and she almost finished within time. And only few things I just tell that cesarean section, that to mention that very little risk for the uh, scar away from the the scar tear. It is very less or no risk. This is the one things. And other things that cesarean section risks for the mom, but like risks or anesthesia risks or operation itself. but baby is less risk, the neonatal morbidity and mortality. But
Exactly.
in case of the normal delivery, there is a risk of that breathing difficulty more. Yeah, about like 5, um, yeah, 4 to 5% for the baby. And but no, sorry, here it
With the
hypoxic and
cesarean section, yeah, the
brain
risk is
brain
more.
damage. Brain damage, that one is more in
Yeah.
the normal delivery. Yeah, and but mother risk is less. Baby
Yeah.
risk is more here. Yeah,
Okay.
and when you ask that for midwifery lead unit, so we can say that yes, there is a but if you like, then we can manage that. There is a we can, but there is a no CTG machine. Yeah, that to monitor you, that if there is any risk of scar tenderness, so there is a we cannot monitor your baby, which will be life-threatening condition. But
Okay.
even though she's insisting, then we can tell her that we can do this Doppler, with the Doppler to check if there is any sign symptom of scar tenderness, so we can shift quickly to the obstetric unit in case if she insisting, and to tell about the that will inform consultant, then he will explain you more, maybe she will
Exactly.
convince.
Yeah.
Yeah,
So whenever we are doing
thank
something which is outside the guideline, it's better to
you. Yeah.
involve the consultant and escalate it rather than taking a decision yourself, because you are a registrar, you're not a consultant. Exactly. Okay.
And I think patient also asks about the that water bath. Also, she
She
asks.
doesn't. She didn't. She just asked about can I have delivery in midwifery led unit. Yeah. It
No,
was just to.
during exam that
Okay.
patient is asking the water bath also.
What do you
So
think? Can she have a water birth?
yeah, she's asking for water. No, another case. I'm telling that
Yeah, so
another case.
I'm
Yeah,
asking, what do you think that if a woman with a previous cesarean section wants to have a water birth, can she have that?
no, she cannot. She cannot. But if
Why
she's
do you think
insisting,
that she cannot have that?
because water bath, there is a we cannot, there is no CTG machine, and also there is a the only midwife will observe her. There is a no doctor, and
No, it's
yeah.
let
Can I
me add.
comment, doctor?
Yes, yes, please. Who's that?
Yeah,
Sorry, I can't
I'm
see.
Mona.
Okay. Yeah.
I'm Mona, yeah.
Okay, Mona. Yeah.
Doctor, no, I think she can have a water birth because
Hmm.
there is we can tell her that we can monitor her baby while in water.
Yeah.
But if we felt any change in the CTG, we can take the patient out.
Yeah.
Moreover, only I have we need to explore her reason why she want the midwifery unit, and we'll inform him, yeah, it's a good option, but that and this and this. And in the next pregnancy, as she wants again one baby, there may be difficulties in conceiving due to scar inside. And also, if you get pregnant, the risk that the placenta may adhere the afterbirth may adhere to the cut. We call it as placenta previa, and you may bleed as well. Only this, but really, I felt that if I'm a patient, it will be too much comfortable for me, because Dr. Falak was saying in a very relaxed manner.
Yeah, yeah. Okay, so
Thank you.
let's let me give you a feedback and then we'll go through the key as well. I think it was very well done, Falak. So even if, especially in exam, when you are sometimes, you are preparing a lot of difficult stations and the stations with hidden agendas and stillbirth and complicated stuff. So sometimes you forget about these kind of simple stations, which are very commonly asked questions actually in the exam. So it was very well done. So you asked with regards to information gathering, you asked about everything. You set a very good agenda. Information gathering was complete. You asked about the previous cesarean section, and especially because I wanted to hear that thing from you. I said to you that my delivery was in a different hospital, so it was really good to ask a permission for case notes. So it's really important. Although we know that if it was a full dilatation cesarean section, it must have been a transverse incision. But how low was that? If it extended toward the cervix or whatever. So it's really good to ask for notes. Any other surgeries you asked, fertility wishes you asked. you summarized the history, and then you asked her concerns, preferences, and birth plan. And it was very good to see that when you discussed both options, because she's more inclined towards cesarean section, so you can appreciate, obviously both options are there for her, we cannot pressurize her, as you said, and it's always important to discuss the option that she would like first and then the second option. Okay, so that was really well done. And yeah, so, and then obviously, as you said, we will support you, we will and appreciate her. Obviously it's your body. Communication with patient was really good. Greeting, introduction, positive patient identification, consent to proceed, and explain the nature and agenda. If patient is upset, obviously offer, for example, with a traumatic birth experience, she may start to cry. So offer tissue and water, and checked her understanding in between, and there were no jargons as to my understanding, and you discussed the pros and cons of different options. The only thing that you have missed is that because when she said that I don't want to end up in an emergency situation, you should have told her that 10% of the women, or 10 out of 100, or 1 out of 10 women, they can go in labor before the scheduled date of cesarean section. And obviously if she ends up in such a situation when she wants a cesarean section, she will come and have an emergency cesarean section, but we cannot promise her the exact timing of that cesarean section, because obviously they will have to adjust it in between the labor ward. Okay, like a cat 3 or
Right.
cat
Yes,
3 section.
I did not think of.
Yeah,
Okay,
so
that's
it's important.
okay.
Okay, but otherwise you asked everything, you told her everything, um, and it was otherwise really good. And so we have discussed this already. And monitoring in case of feedback, as we discussed, on delivery suite sometimes there is a water there is a room with a pool. Okay, so even on delivery suite, if that room is free, she can use that room. As Mona said, that as long as we are able to monitor your baby, yes, you can have that room as well. If there are any concerns, then you will have to come out. I'm really sorry, because if we are concerned about your condition or your baby's condition, then you will have to come out, because obviously that is unsafe. So it's important to tell her if she wants or prefers to have a actually this patient wanted to have a cesarean section, but because I wanted you to discuss everything else with her as well, and intentionally I asked that when can I have a date for my cesarean section, are you going to book me today? Because just to let you know the route, midwife will refer the patient to you, as you had a discussion with her. Then if she wants to have a cesarean section, then it's a different clinic, which is sometimes called the birth choices clinic or mode of birth clinic. Every hospital has that. As you mentioned, that a consultant obstetrician or a midwife will have a chat with you. This is the usual path. Even if you agreed that yes, she can have a cesarean section, this is the usual path. She will go through that, and hopefully when they will agree, she will have a date. Okay.
Doctor, I'm sorry,
Right.
means
Thank you for
the
letting.
birth choice clinic is different from the consultant?
Sorry.
Yeah? The birth choice clinic.
There is a
Means I will refer.
there is a consultant midwife. There is a senior midwife, not necessarily consultant, and an obstetric consultant in that clinic. So that is
Yeah, means I will refer her directly to the birth choice
yeah,
clinic, yeah?
yeah. This is what we
Okay.
do every day. Yeah, even if you don't take the name of the birth choices clinic, every hospital can have a different name. So you can say that I will refer you to my consultant, so that they can have a further discussion, or a consultant midwife, so that they can have a further discussion with you. And once you you make a plan, then we will book you a date for cesarean section.
Okay, doctor. Thank you.
Okay. And with regards to patient safety, I always think that patient safety is incomplete without a proper history, review of notes, as you said, and discuss all options, pros and cons. You did that. Complications monitoring, scar rupture, everything. You did that. Safety net. Safety net is also very important. You offered her leaflet, but always tell women after 36 weeks of pregnancy, or I mean, I'm in my clinic, and I'm sure you guys also do that. In antenatal clinic, you will always tell them what is the emergency number or where they can contact in case of any emergencies. So you can tell her that in case of any emergency, like any concerns regarding baby movements, anything, okay, bleeding, pains, anything else, any signs, symptoms
Yes.
of labor, just call this number. This is the number of the assessment unit, so that you can come to the hospital and we can see what's going on. Okay. And
Yes.
negotiate
Thank you so
properly.
much, Dr. Mara. Thank you.
Yeah, and escalate appropriately. So that was it. Okay, who is the next one?
Me, doctor.
Sorry, who are you? Actually, I can see my screen.
I'm Mona.
only.
I'm Mona.
Oh, Mona, yeah. Okay, Mona. Okay. So this is your labor ward prioritization station.
Sorry.
There is another slide as well.
Yes. Okay.
Next one.
Yeah.
Take your full time. You still have got 1.5 minutes. So take your time and then we will start, okay? It's a long one.
Okay, I'm Mona, one of the doctors in the exam today.
Just hold on, sorry. Listen to me. I am the delivery suite coordinator, midwife. Okay? Okay, and we will have a chat regarding all these patients to make a plan for today. Okay?
Okay.
Okay, so just imagine that you have taken the handover and then we will have a discussion about these women and then we will make a plan. Okay?
Okay.
Okay. Hello, Mona.
Hello.
Should we catch up to make a plan for everybody?
Yeah, let's do it.
Yeah.
Okay, now I want to go room by room.
Sure.
Okay. First, let me see. First one, para one, she had the cesarean section for breech yesterday afternoon, and she was taken back to theater for bleeding at 2 a.m. And drain sighted, blood loss. Okay, I want to know more about this patient. What happened during the operation last afternoon?
I don't know. I mean, I haven't seen the notes, but it seems here that the angle was bleeding, and that's why she was reopened. Yeah, bless her.
Okay, and is she still bleeding?
No, I think she's stable. She's in the observation room.
Okay, so this patient had lost 2,500 milli. Okay, so we will need to put the patient on the mute chart, and so and monitor her vitals. And this patient may be at increased risk of continuing bleeding. Yeah, and so we inform my consultant about this patient,
Okay.
and we inform the anesthetics as well,
Okay.
as this patient may need to be transferred to the ICU. Um, 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 that's it. If the patient is stable, we'll monitor her vitals, and we'll also take blood tests to see her hemoglobin, what is about her hemoglobin at the moment.
Okay.
So we'll send, yeah, we'll inform my consultant about it, and we can send who's competent to the patient. This is now at the moment it is a semi-urgent case,
Okay.
so
Okay.
we can send the ST4 to this patient.
Okay. So
Then I
we
will go
don't
to
have
the
any
second
ST4
room.
today, Mona. It's just you and the SHO and the anesthetic registrar and midwives for each woman.
Yeah, okay. So we will send the midwife to monitor the on the mute chart
Mm-hmm.
and monitor if there is any bleeding and inform me.
Okay, that's fine.
Then the second patient is para 2, 37 breech presentation, spontaneous labor, 6 cm regular contractions, and breech at spines. Okay, I want to know from the patient, if the patient knows that knows about the breech delivery,
Mm-hmm.
that she may deliver breech.
Mm-hmm.
Okay, and if there is the breech is at spine and she's still 6 cm, we can do ultrasound to see if the prerequisite for breech presentation is met,
Okay.
so that we can deliver her normal, and also will inform my consultant about this patient.
Okay.
This patient will need to be put on continuous CTG,
Okay.
and to monitor the progress of the patient,
Okay.
and so I will send the midwife to monitor her in labor.
Okay, that's
So
fine.
then the other patient, 20 weeks, membranes intact, termination of pregnancy for Edwards syndrome, stopped the contracting. Okay, this patient, if she stopped the contraction, so this is an routine case. It's not urgent now. And so we can send the midwife to see if to examine the patient again, and as the membrane is intact, we will and if there's no progress, then we will apologize for the patient, and to apologize that when we finish the urgent and semi-urgent cases, we will return to her again. Then we have
So
the other
should the
patient.
midwife who is looking after her examine her now, or what do you want?
Yeah, I want examination now.
Okay, that's fine. I'll ask her to do that.
Okay.
That's fine.
Okay, thank you. So the other patient, 40 weeks term, meconium, contracting spontaneous labor 7 cm at 8 a.m. Urge to push. This patient will need I want to know the CTG of the patient. She need to be put on CTG if she is not on CTG, and to see how the CTG is going. And I want to examine. I want to send the nurse, the midwife, to examine the patient now.
Okay.
Okay, so see to see what is the examination at the moment,
Okay.
and that's it. And they inform me about this patient. Then we have the 26 weeks tightening, glowing pain, abdominal discomfort. This patient may be a preterm, maybe in preterm labor, and so we need to examine. She need examination as well, and to see if the membrane is intact or no, and to hear the fetal heart sound. Then this patient, I will send also the midwife, as we need to, as after the examination of the patient, we will decide what to do, and we need to inform the pediatrician to see if there is cot available. As if there is no cot available, we will transfer the patient. So this is a semi-urgent case. I can send
But I
the
think our hospital can handle this because our neonatal unit is good. So I think we can handle this baby. So let me call the SCBU and check the status. Yeah, I'll do that. Okay.
Okay, and so this patient, if we will need the corticosteroids, 2 doses, 24 hours apart, 24 hours apart, and if she entered into active labor, so we'll start the magnesium sulfate and the intrapartum antibiotic.
Okay.
So yeah, then I will go to the other patient, 37, diabetic, insulin dependent for induction of labor. We need to know the insulin, the blood sugar at the moment, and we need to know if she's feeling any dizziness or anything. And then she need to be examined vaginally, to see the bishop score. Is she suitable for induction of labor? And so I can send the midwife to apologize for the patient that if the blood sugar is normal, so we can this is a routine case, so we can finish the urgent and semi-urgent cases first.
Okay.
Then we'll go to the other patient, 40, contracting 4 cm at 4 hours. Repeat VE at 7 hours, still 4 cm. This patient will need the examination of the vitals and need to examine the abdomen if there is any tenderness in the abdomen, and to examine the patient vaginally. When was last time she was examined?
7 o'clock.
Yeah,
This
so she
morning.
need to be examined. Yeah, she need to be examined again, and to hear the baby heart sound. If it's still not progressing, then we can do ARM and see the color of the liquor, and inform me about this patient.
Okay, that's
So
fine.
this is a semi-urgent case. I can send the midwife as well. Then we have the delivered at 6 a.m. awaiting suture, 200 milli. So she is delivered. I will send the midwife to cover the patient and to see if the patient is bleeding and or no. If there is no bleeding at the moment, and so we need to know the degree of the suture. If it is, I will send the nurse that can suture the patient to suture the patient now. So this is a semi-urgent case. Now I have the other for elective CS now contracting. This patient needs, she's previous 3 cesarean section, so this needs patient needs examination and
she is one cesarean section. She
once.
yeah.
Okay, she is for elective cesarean section. Okay, then
Sorry,
we'll
she is a
send it
prime
again.
if, but she wants a cesarean section. She came in contracting.
Okay. Then we'll send the nurse to talk with the patient and see why she wants the cesarean section, and is she signed the consent for cesarean section, and she know about the pros and cons of each. And we need to examine the abdomen of the patient and to put the patient on continuous CTG and examine the patient vaginally. As this patient may need to go to the cesarean section, to be delivered by cesarean section if she consent for this, as she is contracting. So we'll inform inform the ST4 or ST5 about this patient who's competent to do the cesarean section.
Okay, so but you are the only ST5, okay?
Yeah. Okay. Then we'll send the midwife to monitor the patient until I finish from the urgent cases.
Okay, that's fine.
This is a semi-urgent case. Then I have bara one previous one cesarean section, blood stained, antepartum hemorrhage, contracting, complaining of pain between contraction, early deceleration on CTG. So this patient may be a placenta abruption, and so I will go to this patient, and then I want to know the amount of bleeding she had at the moment, and to monitor the patient vitals on the mute chart to see if she is stable, and examine the abdomen to see if there is any tenderness, and examine vaginally if there is time to also do ultrasound to the patient if there is time. This patient have early CTG on early deceleration on CTG, so we will do continuous CTG and see if the patient previous one cesarean section, to review the notes quickly to see if this patient has placenta previa or placenta accreta. And then we may need to deliver the patient by cesarean section, emergency cesarean section. So we'll inform the midwife coordinator and the anesthetics as well, as this patient may need to
Your
be
time is
taken.
up, but just complete the station.
Okay, this patient may need to be taken immediately to the cesarean section.
Okay.
And we will assign consent, see if the consent is ready.
Okay. So where do you want to go first? Which room?
The room, the last room, room 10.
Okay, so you are going in room 10. And what do you want me to, where do you want me to go now?
For the patient room 2.
Okay,
She's
that's fine. I'll
continuously
go
with
to
6
room 2
cm.
and you go to room 10, and I'll also call the consultant. Thank you. Okay, we've
Thank
got
you.
a plan.
Thank you.
Okay. All right. Who wants to give a feedback?
I want to give a feedback. So I think Mona did a very good job. She covered all the important things, but the only one thing that I want to point out here was that I can see that room number 10 is the urgent case, and I might not be able to talk about it if I take it as the last. So what I would have done, I would have started with room number 10, and maybe then I would have gone room wise because I'm scared I might have missed it, and it needs a lot of things to talk about. This is and I think Mona missed that she was previous one, so it's not only abruption but probably it could be rupture. So I am thinking about rupture more, and so this would have been my first case that I would have discussed. Rest, Mona's management was perfect. Coming
You're
with
right.
room number one, I might have involved the anesthetist in this case because she needs, obviously, she has bled a lot. Possibly, she would need fluid management, repeat set of bloods, and checking of the Meo's chart. So I would have sent the anesthetist to room number one. Room number two, yes, of course, I would have called my consultant because we have two urgent cases. Room number two is also urgent case. So I would have liked to call my consultant also. And maybe when the consultant arrives, then he could go to room number two because I don't know if he is going to be available in the next few minutes or not. Otherwise, I think Mona managed it very well. I just have one thing to say. In room number 8, the patient had delivered at 6 a.m. and now it's 8:30. So it's been 2.5 hours. She has been waiting for suturing. So it has been a long time. This is now, I think she should be seen urgently. And I don't know, Dr. Mara, do we need to report this incident? It has been 2.5 hours
I
waiting
mean,
for
if she is not
episiotomy.
bleeding, and obviously if the delivery suite is busy, and there is also handover, because generally the midwives are handover at 7:30 and then the doctors at 8 o'clock. So because of that, if there is a
Okay.
delay and the new coming team can manage it, yes. So I don't
Okay.
think that we need to report that, but I'll have to check, to be very honest.
Okay, okay. Otherwise, I think it was very good.
Okay, yeah. Thank you so much. Okay, so the only thing that I want to add is that I think, as you said, room number 10, she can discuss first, just because of the fact that, she might miss it, because that's the most important room. So that's your priority, isn't it? So, and secondly, if you, for every room, if you say just in the beginning that this is an urgent room, this is a semi urgent room, and I will send XYZ here. For example, for the first lady, you said that I don't know why did you mention about ICU. Maybe you got a bit confused that she has bled a lot and she went to theater, so we may need an ICU bed. But I told you that she's stable at the moment and she's in one of the observation area rooms. So anyways, so you can tell that this is a semi urgent case, or she's, because now she's stable. It's good to know that she's stable, but we need to do some things for her. So this is a routine case or a semi urgent case, and I would like my anesthetic colleague to go and see this lady while I'm managing the other case. Okay, so this way, tell what is the level of urgency and who will go there, and then using an smart pattern, you can just summarize the case. You don't need to say each and every word which is written here, because obviously that will waste your time, and then and time is important, especially in a scenario where you've got 10 patients, so you have to talk about each and every patient. So that's yeah. And also for room number 2, as you said, that it's important to call the consultant. So you will ask the midwife that can you please call the consultant, because this is out of the competencies of ST5. You can't deliver a breech vaginally, and obviously for a cesarean section as well, because you also have to go to attend room number 10 with regards to the stuffing. You need some help, so the only person you can call is your consultant, remember that. Okay, in any labor ward scenario, whatever staff is mentioned, you cannot call an extra registrar. And always be mindful of the fact, this is situational awareness. Be mindful of the fact that who is present with you. It's just you. On most of the time on delivery suite, there is only one registrar, and that is you. Okay, there might be an ST1 or ST2 or an FY. So it depends upon what they have mentioned. Sometimes they have written that, you know, the FY is like a GP trainee, or sorry, the FY is like a foundation year doctor, obviously very basic, like house officers in our country. And if there is a like ST1 who is a GP trainee, then they are not competent in doing cesarean sections. They cannot also consent the patient and stuff like that. But if it's like a gynae ST1, then they can at least consent the patient. So you have to be mindful of these things when doing a labor ward prioritization. So for Ford, you will ask your consultant to come, and obviously the rest of the things that you mentioned, that, you know, we have to review her notes, review her obstetric history. We don't know, she's para 2, but it's not mentioned whether she's previous to cesarean sections or she's had 2 vaginal deliveries. So I would like to know a little bit more about her, review her history, and ultrasound scans, where is the placenta, and on her previous ultrasound scan what was the baby's weight. And we also have to do an ultrasound scan to see the attitude and the flexion of the head, and what kind of breach is that. So would you mind asking the consultant to come and deal with this patient, because it's an important case and I have to attend room number 10 as well. So for room number 3, you managed well. The attending midwife, it's not an urgent case at the moment. Attending midwife can do an examination now, and then she will let you know. And for some of the semi-urgent cases, you can also say that after I'm done with room number 10, then I will go and make a plan, etc., etc. Okay. And for room number 4, who had meconium, she's a para naught, she had meconium, so she is having some urge to push, as you rightly said, that the midwife can examine her now to see if she's fully dilated. The only thing is that I added meconium here because in that situation you will call the neonatal team to attend this baby. Okay, even if everything else is normal, even if CTG is normal, she should be on CTG, because women with meconium, they are always transferred to delivery suite even if they are low risk to have a CTG. So she should be on CTG. So it's important to make sure that the CTG is okay, and she would also need to be baby would be need to reviewed by the neonatal team. And who is next? Then yeah, tightening loin pain. So yes, so you have mentioned everything else. So your SHO, the ST1, can go and examine this patient. Midwives generally don't assess these preterm, very preterm, and these kind of patients. They don't do that. Okay, so this is beyond their level. So you can ask the obviously they will be looking after all the women who are in the delivery suite otherwise, and but with regards to making a diagnosis and you know, if whether she's in preterm labor, so your SHO can go and assess this. So she needs a doctor review, okay, because she's also having some loin pain and tightening, so it may be UTI. So but we have to see, you know, I have a key actually in the next slide. Let's go to that. Okay, room number 1, now she's stable. So I have marked it as green. 2 and 10 are red. These are semi-urgent, the 3 cases. Okay, we have discussed them. For this lady, we can apologize, as you said. So one of the midwifery support workers or one of the midwives looking after this lady can go and apologize, but she would need a plan later. We will review her notes and see what is the plan of monitoring during labor, whether she needs to be on variable rate. She would need to be variable rate insulin or a sliding scale, and monitoring of her frequency of monitoring of her blood sugars, and what is the plan for induction. I mean, based on the examination findings, whether she will need an ARM, an oxytocin, or she would need a prostaglandin. Okay, and this second, room number 7, as you said, that she was still 4 centimeters. So we need to know whether she is she has intact membranes or not. But because if she hasn't progressed, because here we generally do not rupture membranes unless there is concern. If a woman is progressing well, we do not need to rupture membranes. So if there is a concern regarding progress, she can have ARM and then obviously oxytocin augmentation. So she will need a plan. So you can say that I will ask the midwife to examine her now, but once I'm free from the emergencies, then I can go and have a chat with them regarding whether we should augment this lady or okay. Because if the membranes are ruptured and she's still 4 centimeters, and there are depending upon the findings, she may be obstructed labor. So that is why she will need a plan by you later on. Okay, 8 is kind of routine because she's not bleeding. And then for this lady, as you said, that the midwife who is looking after her can apologize to her. Sorry, no, she is labor. She is an elective section, but now she has come in labor. So the midwife can assess her and see which stage of labor is she in. As you said, she can have a CTG full assessment, and then we can have a discussion with her whether she would still want to continue with the plan of going ahead with the cesarean section, or she would like to try for a vaginal birth. And room number 10 was well managed otherwise, but I think that for each and every room you should tell them that this is a semi-urgent, urgent, and a routine case, and who will you send. Okay. And obviously situational awareness with regards to your staffing, that is important. Otherwise you know how to manage the patients. Well done, thank you. So with regards to the labor ward team, we have got midwives who are independent practitioners. They are not, they have their own skill set. So advanced skills are cannulation, suturing, and prescribing. Okay. And they hardly prescribe any medicines, but most of the time they can suture and they can do cannulation. And SHO, as I said, variable level of skills. They could be foundation year, they could be GP trainees, they could be your own ST 1 or 2 gynae trainees. Okay, and then is the anesthetist. Obviously they can do epidural spinals in GA, and they can give their input in managing critically ill patients. Okay, and consultant can come whenever needed, and also the anesthetic consultant can come whenever needed. We all know that there are two ways to tackle. The preferred option is to go room by room, but it's a good idea to mention your first priority, because that was on number 10. Otherwise, if it would have been room number 3 or 4, you may have left it like room wise. Okay, and I think we have discussed actually all of these things, so we don't need to go through that. Okay, done. Hello,
Dr. Amar.
yeah.
Yeah. Dr. Amar, I just wanted to know this patient, if they are not progressing, delayed progress, can we start oxytocin without ARM?
Oxytocin without ARM, no.
No?
No. 4 centimeters dilated lady, you mean?
No, any patient in the first stage, like she is around 3 centimeter. You want to know this because she is having meconium
I
or
didn't get
something.
your
We will do
question
ARM, right?
completely. Sorry, Sunanda. Can you please repeat your question? Make it a little more clear.
Yeah. Yeah, now see, patient is not progressing in labor. She's having incoordinated uterine contraction.
Hmm.
Can we start oxytocin without doing ARM
No, because
to get?
no, you can't. Because the reason is that unless it's a tightly closed cervix and you are not able to do an ARM, it's
Mhm.
better to do an ARM and go in the proper sequence. Do an ARM and then start oxytocin. When you are able to reach the membranes, there shouldn't be any point in delaying the ARM and just starting oxytocin.
Okay.
Yeah.
Thank you.
Thank you, doctor.
Thank you so much.
Thank
Should
you.
we
Thank
call
you
it
so
a
much.
day? Thank you very much,
Dr.
everyone.
Amar,
Yeah.
just one
Thank you,
question.
Dr. Amaral,
Yeah.
for
Yeah. Please ask.
Just I'm a bit confused regarding the breast patient. I understand that the ST5 is not competent to do breast vaginal delivery, but it's still like I see like it is not like urgent. I will call the consultant,
Hmm.
but it is not like urgent because like there is no concern regarding her now.
No concern regarding her at the moment. Yes, so we will wait
Yeah.
for the consultant, because this lady needs an assessment as a plan. For example, in this scenario, if there wouldn't have been room number 10, okay, in this scenario, if we didn't have room number 10, let's go back to that, then this room is your priority. Okay, then you can go in that room. Okay, you can assess this woman, but I would still encourage you to ask your consultant to come for this delivery. The reason is that this is the breech delivery is a part of the advanced training module. Okay, of labor ward advanced training module. It's not a like a competency, it's beyond the competency of ST5. So in such a situation you will call your consultant.
Yeah, okay. But still, I consider it like urgent.
Yeah, I mean, she's 6 centimeters dilated. She's para 2. She may just push the
Yeah.
baby out any time. So it's an urgent. Yeah. What if the body delivers and the rest of the the bottom delivers, rest of the body doesn't deliver? What will you do? So it's an urgent case. Yes.
Okay, yeah, because of that. Yeah.
Yeah.
Clear now. Thank you so much.
Yeah. Any other questions?
Can you show the case 4 slide?
Case 4. Last one, station 1. Sorry, station 4. This one, that was a case of a diaphragmatic hernia.
Yes, that and the labor ward also.
I'll share the recording, don't worry.
Okay. Yeah, this one and then last next one.
Okay.
Next one. The case 4 you have written, no, in a different slide.
So we had 4 cases. The first one was a dermoid cyst.
No. This only. Yeah, in this only. Labor ward.
Oh, okay. Case 4.
Station. Yeah, next slide.
Okay. Here. This one.
After this. After this. After this. The next one. Yeah, this one.
Yeah, so
thank you.
I have mentioned that because this lady is I don't know whether I have mentioned the parity here or not, but that's a grand multi probably I have written. I don't know, there is something missing probably in the previous slides. So in that case we also have to do the active management of third stage of labor. And for any of the like the case number 1, we also have to speak a little bit about the touch, at least the clinical governance bit of that. That duty of candor will be done and debrief the patient, okay? Because she returned to theatre, so that's also an incident. So for any of the clinicals, all the scenarios, you will do the clinical bit and also the clinical governance bit. Okay, so thank you so much everyone for attending the session.
Thank you. It was a very useful session.
Okay, thank you.
Thank you so much.
I'm really sorry. I just want to ask one question, please. Regarding the patient, like if we have patient with any contraindication for home delivery, like cesarean section or fibroid, and she insists to deliver at home, can we give her the long side midwifery option, midwifery unit?
Yes, so any patient who should actually be delivered in the delivery suite, you will give her other options as well. Obviously, we cannot, as we discussed, that we cannot pressurize any patient to do what we think is the best for them. But we are there to tell them the options and also the recommended management, because we are doctors. We are not just there to, tell them like a leaflet. We are not a leaflet, isn't it? Because it depends upon the leaflet just tells us, 1, 2, 3, 4. But we are doctors, so here comes your applied clinical knowledge. So you will tell her, so this is a recommended option for you. I mean, if for example, previous 2 cesarean section, she wants a home birth. It's not possible, isn't it? So what we can do is to tell her that, this is not the recommended option for you. Even if you want to try to deliver vaginally, it should be in the hospital. Okay, this is our recommendation. But if you still want to have that, the other options are that you can deliver in a midwifery led unit. But the midwifery led units which are away from the hospital, it's like a 45 to 45 minutes to an hour distance. Okay, even with ambulance, 45 minutes to half an hour distance. So alongside midwifery led unit is within the hospital. It's a very good question, thank you. That is within the hospital, so it's just a 5 minutes transfer. So we can give them this option. Yes.
But is the midwife at the long side, they will accept her? Because my understanding, they just accept the patient with the low risk patient.
Exactly.
Right.
Yeah. Yeah. So they will only accept the low risk patients, but any patient, as I told you, who is demanding something which is out of the guideline, we will first of all refer them to the consultant.
Yes.
Okay. And then obviously give them options. We are here in this exam. You are there to give them the options. Okay. And also, whenever they think that you think that this is not a reasonable option, just refer them to the consultant so that they can have a chat with the consultant.
Thank you so much, Dr. Amara. Thank you.
All right.
Excuse me, Dr. Amara, can I interrupt here a little bit? The alongside midwifery ward, they do the CTG.
No.
Yeah, so we can what we can say about the CTG.
I mean, this is what we recommend, because obviously we want them to have CTG, we want them to be in delivery suite where there is an easy access to doctors and operation theatre. But if they don't want anything, then at least in the midwifery led unit they can have the auscultation. I'm not saying that this is the right option for them, but I mean, this is what if she wants it and she's insisting on that, you can't force her. But they don't have a CTG facility, no. It's
But
like
we can
any other
arrange.
unit, any other midwifery unit. It's just like any other midwifery unit, but within the hospital.
Yeah, but can we say, if patient is insisting, can we say that we can arrange for her especially
No.
for her
No.
CTG? No.
No,
All right.
because
Yeah.
we are not going to go out of the way. There is also we also have to look at the staffing. Okay, who will interpret the CTGs there? There are no doctors there. Okay.
Yeah.
Yeah.
Yes. Thank you very much.
Yeah.
Yeah.
You're welcome. Okay, thank you very much, everyone. We'll
Thank
see
you so
each other
much.
later. Thank you.
Thank you.
Thank you very much, Dr. Amara.
Thank you. Thanks for participating.